Welcome to the PHINE Quarterly Update, originally given at the PHINE Network event in Newcastle on the 17th of May. We've developed this presentation to better share the updates from the PHINE Network events to our audience. In this presentation, we will look at the latest tools, profiles and publications. We'll also look ahead at health intelligence outputs that will be made available in the near future. Injury profiles were produced by the South West Public Health Observatory in March on behalf of all public health observatories in England. They provide an overview of injuries occurring in each local authority in England. The aim is to highlight the burden of injuries and the large variation in injury rates across England. Interactive maps and charts enable comparisons to be made regionally and nationally for over 40 injury-related indicators. The indicators are grouped into themes such as general injuries data, land transport, falls, selected injuries such as burns and hip fractures, intentional injuries, and hospital admissions due to other selected causes such as drowning. The results show that in England there were over 650,000 hospital emergency admissions due to accidental injury in 2010-11. And almost 11,000 people die each year from accidental injuries. This slide gives a snapshot of the tool, which like many observatory tools uses Instant Atlas to show results numerically, in spine charts, in bar charts and on maps. We see northeast results for the indicator hospital admissions due to fall injuries. The bar chart shows that North Tyneside has a significantly higher value for this indicator than any other area in the region. The spine chart on the right of the screen shows how North Tyneside compares with all other areas of the country for other indicators in the injury profiles. There seem to be some areas of concern in the general indicators and in the falls indicators, which may require further investigation. The data can be downloaded for a more in-depth look, and full indicator descriptions are also given on the website. Child health profiles were originally produced by the Child and Maternal Health Observatory in 2011, but they were updated in March 2012. The profiles can be viewed either through an Instant Atlas tool or as a 4-page PDF report for each local authority in England. The profiles now include spine charts to provide a quick summary for each local authority. The PDF reports compare local authority results for some indicators with comparisons to the results of their statistical nearest neighbours. This is probably more usual comparison in local authorities than it has been in PCTs in the past, and it's likely to become more commonplace in public health tools in the future. This slide shows the spine chart for Middlesbrough, and the red dots show a number of indicators which may require further investigation. The Child and Maternal Health Observatory have also published a new automated report on vaccination and immunisation rates among children at PCT level. This is a 4-page report summarising vaccination and immunisation rates. This slide shows a table taken from Newcastle's report and shows that Newcastle's HPV vaccination uptake rate was 87.6% in 2009-10. Slightly down from the rate in the previous year. However, Newcastle is still performing well on this indicator, with rates higher than the average for the North East and for England as a whole. This slide shows a chart taken from the child health profile for Gateshead. It shows the indicator breastfeeding initiation in 2010-11 as a percentage of the maternities where the status of breastfeeding was known. It shows that Gateshead's got pretty good performance in this indicator, and it compares it against Sunderland, South Tyneside, County Durham and North Tyneside, which are the statistical neighbours for Gateshead. Gateshead has pretty good results compared with all of these areas and with the North East as a whole. However, there's still work to be done to increase breastfeeding initiation rates to those of the England average. The latest report from the End of Life of Care Intelligence Network focuses on deaths from liver disease. It shows that there has been a 25% increase in liver disease deaths between 2001 and 2009. This is in contrast to other major causes of death which have been declining. Although numbers of deaths due to cancer, vascular or respiratory disease are still much greater, liver disease kills people at a much younger age. A striking 90% of people who die from liver disease are under 70 years old. When measured as years of life lost, liver disease is therefore much more prominent. This slide shows a graph from the report which shows deaths from liver disease by deprivation levels. The largest number of deaths from liver disease are due to alcoholic liver disease, shown in the bars on the left of the graph. The tallest column, in dark blue, shows the number of deaths from alcoholic liver disease in the most deprived fifth of areas of England. You can see that the number of deaths is over 3 times larger than the number of deaths from alcohol liver disease in the least deprived fifth of areas in the country, shown by the light blue column in the same cluster. The pattern can be seen to a slightly lesser extent for each of the other underlying causes of death from liver disease, highlighting consistent health inequalities. There are a number of reasons why end-of-life care for people with liver disease is particularly challenging. Most of all, perhaps, it's challenging because the cause of their death may have been preventable. With over 70% of people with liver disease dying in hospital, this report helps to understand the challenges in managing end-of-life care for this patient group. Figure 19 from the report is shown on this slide, and it highlights how common it is for people who die from liver disease to die in hospital. As previous reports from the End-of-Life Intelligence Network have shown, most people would prefer to die in their own home, but this seems to be relatively rare for people who die from liver disease. The National Child Measurement Programme has been running for several years now, and the National Obesity Observatory have produced a report describing the changes in children's body mass index between 2006-07 and 2010-11. The next few slides summarise the results. This graph shows that obesity prevalence has been increasing for Year 6 boys and girls, but the picture for reception year children has been more mixed. This chart shows the difference in obesity prevalence between the most deprived areas on the left of the graph and the least deprived areas on the right of the graph. You can see that in the most deprived areas of the country, obesity prevalence is significantly higher than in the least deprived areas. You can also see, if you look more closely at the columns of data, that there's been a bigger increase in obesity in the most deprived areas than there has been in the least deprived areas, although the least deprived areas still have increasing obesity levels too. The slope index of inequality estimates the difference in obesity prevalence between the most and least deprived areas of the country. If the slope index of inequality shows a significant increase over time, this suggests a widening of inequalities. For boys in reception year, the slope index of inequality for 2008-09 and 2009-10 was significantly higher than the slope index results for earlier years. For girls in reception year, there was no significant change in inequalities. For boys in Year 6, again, there was no significant change in inequalities. But for girls in Year 6, the slope index of inequalities for 2009-10 was significantly higher than for 2007-08, which does suggest a widening in health inequalities in these areas. The NHS Atlas of Variation series has been created to highlight unexplained variations in care, giving clinicians and commissioners a focus for improving care. The first NHS Atlas of Variation was published in November 2010 and looked mostly at the care of adults. A new atlas has been produced which focuses on the care for children and young people. It incorporates 27 indicators, all shown on maps, so that the extent of variation and any geographical clustering of results can be seen. This slide highlights some of the recent outputs from public health observatories. Cardiovascular disease profiles for PCTs have been updated by the South East Public Health Observatory using the latest data. Each profile contains a summary spine chart showing a number of selected indicators in a simple format, a more detailed profile showing indicators in graphical form and with longer time frames or different comparators, and an interactive atlas allowing the indicators to be compared across the country by PCT or by cardiac networks. Spend and outcome tools and fact sheets have been updated by the Yorkshire and Humber Public Health Observatory, and this slide shows an extract of the Spot fact sheet for Darlington. This is a rather neat tool that brings together a range of information to compare how much your PCT spends on different things. We can see that Darlington's spend on mental health per head of population dropped last year and is lower than that of the North East as a whole and England. Public Health Observatories produce a dataset of 51 indicators to help local authorities and PCTs carrying out joint strategic needs assessment. The indicators, available at middle super output area level, have recently been updated. The data can be accessed from the AFO website, afo.org.uk, or through the Public Health Observatory's Local Health tool. This provides interactive maps, such as the one shown on this slide, and MSOAs can easily be combined using the tool to create custom geographies. The Eastern Region Public Health Observatory has produced a new set of training videos to help people get the most out of PHO tools. One video explains how to interpret spine charts, which I've mentioned a lot during this presentation. Spine charts are included in many profiles such as health profiles and the CVD profiles I've just referred to. Another video describes funnel plots, a kind of graph which can help to identify outliers. More training videos are planned. Since April 2011, local authorities have been asked to assess themselves against 7 outcome goals and 3 service ambitions. These include statements such as adults with autism achieve better outcomes, adults with autism are no longer managed inappropriately in the criminal justice system, and local authorities and partners know how many adults with autism live in the local area. The Learning Disabilities Observatory has produced a preliminary report on the Council's responses. Initial findings suggest that service planning is working well, but work with the criminal justice system and on improving health outcomes require more attention. Also coming soon from the Observatory is the report People with Learning Disabilities in England 2011, an annual summary of statistics on the health and care of people with learning disabilities. This will be published on the 23rd of May. Finally, a reminder about information coming out soon. Health profiles are produced annually, and they provide a snapshot of population health in each local authority. They're designed to help local government and health services understand their community's needs, so that they can work to improve people's health and reduce health inequalities. The new profiles will be released on the 26th of June. Information from the 2011 census will start to be released from July this year. Data will be released on the population by age and sex for England and Wales and for each local authority. It's important to note that financial allocations made to local authorities and to NHS commissioners will be based on population estimates from the census, so it's very important that they're accurate. Initial results from the 2001 census underestimated the population of Manchester by over 25,000 people, and it was checking and lobbying by Manchester and other areas that pushed the Office for National Statistics to undertake additional work to improve the estimates. People in Manchester are already producing local estimates, comparing general practice populations and registered electoral populations in readiness for the new census. This might be work that people want to think about doing locally.